Next presentation, Mohd Zakhiri Mohd Rashid, Transforaminal endoscopic lumbar discectomy versus percutaneous laser disc decompression. Clinical consideration and outcomes. Трансфорамінальна ендоскопічна поперекова дискектомія проти перкутанної лазерної декомпресії диска, клінічні міркування та результати.
Yes, okay. Hi everyone, I'm Zakhiri Rashid from Malaysia. First of all, I would like to say thank you to my friend Dr. Yuri and the organizing committee for inviting me. I really hope actually I can be there personally. I would love to be in Ukraine, but however the circumstances prevented me from going there. Now, hopefully next year I can go there and meet Dr. Yuri there. Today I'm going to talk on transforaminal and interlaminar PLD versus percutaneous laser disc decompression, which is PLDD. This is my disclosure. So how exactly we choose the best endoscopic technique? The aim of endoscopic procedure is basically to have an adequate decompression, and at the same time we want to minimize the collateral damage as much as possible. In my opinion, there is no one best endoscopic technique and approach, so we need to choose the best technique and approach for the particular cases. And transforaminal and interlaminar are two main approaches in endoscopic spine surgery. So about the transforaminal approach, it is basically discectomy through the transforaminal window. It is the least invasive of all the MIS technique. It's mainly targeted fragmentectomy with minimal disruption of normal anatomy. And the endpoint is free mobilization of the thoracic and the nerve root. How about the interlaminar approach? Basically, it's an endoscopic approach through the interlaminar window, which is more familiar, especially for open surgeon. It has a more flexible working window, and the endpoint is the same, which is the free mobilization of the thoracic and the nerve root. So what about percutaneous laser disc decompression? As compared to PLD, this is a non-visualized technique as compared to PLD, which is a visualized technique. The disc tissue basically is vaporized, reducing the intradiscal pressure, and it will reduce the size of the disc herniation by thermally shrinking it, and it will have the volumetric decompression and thermal denervation effect, which will reduce the pain. So what are the things to be considered for transforaminal approach? So basically, if we look at the anatomy, there is a narrow interlaminar window in the upper spine, but the foramen in the upper lumbar spine are wider and larger as compared to lower lumbar spine, which allow the easy access of endoscope. However, for the transforaminal approach, we need to be more precise in entry point. The entry point basically move more lateral as we go more distal towards the lower lumbar. And we have to do more markings, obviously, preoperatively, because it needs to be more precise as compared to interlaminar approach. And there will be more radiation exposure as well, if this is something which is a concern for the particular surgeon. So this is one thing to be considered, that for transforaminal approach, definitely we will have more radiation exposure because we need to take more views as compared to interlaminar approach. There will also the unfamiliar view initially when we do the transforaminal approach. This is the example of the initial half and half position view when we do the transforaminal approach. And intraoperatively also there will be unfamiliar view as compared to interlaminar approach, as well as there will be also unfamiliar endpoint as compared to interlaminar approach. There will also be less nerve retraction in central disc as compared to interlaminar approach, and like this case that this is removal of central disc done, so without retraction of the neural elements. It also offer alternative virgin approach for recurrent case like this case. This was done by open surgery with spacer many years ago, she came back to me with the recurrent disc. So I approached this with a transforaminal approach. This is the MRI. This is the intraoperative findings after the removal of the disc, versatile dura. And this is the pre and post-operative MRI showing that the disc has been removed and remodeled nicely. So what are the things to be considered for interlaminar approach? For interlaminar approach, if we look at the anatomy, so basically there will be a narrower interlaminar space in the upper lumbar spine as compared to the foraminal space. There will be more bony work due to narrow space in upper lumbar spine, and there will be wider interlaminar space in lower lumbar spine. So basically, it's sort of the anatomy is telling us that the lower lumbar spine interlaminar approach is better. For the upper lumbar spine, the transforaminal approach is better based on the anatomy. So there will be less radiation exposure in interlaminar approach. There will be more familiar view. This is like what we do in open or tubular surgery. There will be also familiar endpoint. So we can see both the nerve root. If we clear both sides, we'll see the nerve root clearly as like we do in open surgery. So what are the things to be considered for percutaneous laser disc decompression? Since this is a non-visualized technique, for this technique, we need to be very, very precise in entry point. So the entry point also move more laterally as we go from upper lumbar to lower lumbar spine, but generally the entry point are more medial as compared to transforaminal PELD. If let's say at the L4-5, maybe for the transforaminal we approach at maybe 12 centimeter. So for PLDD, the approach maybe would be around 8 to 10 centimeter. So usually we will use the biplane fluoroscopic view to get the disc at the to get the needle to the center of the disc. Like in this view, for the L5S1, sometimes we can use the bevel of the needle to bend the needle. Like in this case, actually I didn't bend the needle, but the needle bent itself by grazing the end plates. So after we put the needle in, a laser fiber is inserted through the needle into the center of the nucleus pulposus. The laser energy is then delivered to the nucleus to vaporize its content and reduce the intradiscal pressure. So what the literature say? For transforaminal approach versus the interlaminar approach, there is more durata in interlaminar approach cases, but there is no difference in post-operative dysesthesia, nerve root injury, wound complication, recurrence, and incomplete decompression based on this paper. According to this paper, there will be less post-operative back pain in transforaminal approach cases. However, there are a few papers mentioned that there will be more post-operative paresthesia in transforaminal approach because of grazing or injury of the dorsal root ganglion. And about the learning curve, the cut-off points to master both approaches, it will take about 50 cases for interlaminar approach and about 23 cases for transforaminal approach. And when we compare the transforaminal PLD with the PLDD, so basically transforaminal endoscopic decompression for symptomatic herniated disc is very effective, it's durable. And for the PLDD, basically it can offer a good result, but it's more in short term as compared to long term. Like in this paper, it's mentioned that the median survival time is 66 months for PLD and only 70 months for PLDD. It means that about 50% of patients will have a recurrence of symptoms 70 months after they had PLDD as compared to 66 months for PELD. And according to this paper, about the 8 surgical intervention for lumbar disc herniation, both the PELD and PLDD were the safest procedures for lumbar disc herniation with minimal intraoperative and post-operative complications. And when they compare to PLDD with conservative treatment, it shows that PLDD appears to be a viable alternative to conservative therapy. And they propose, according to this paper, for PLDD to be used early in the therapeutic regimen to accelerate short-term clinical improvement. And another paper comparing the 7 surgical intervention show that actually PLD is the best one, even better to the all other techniques that they studied in this paper. So my recommendation would be the zone of herniation should always be considered. PLDD should only be considered for contained disc with the good disc height. But otherwise, for foraminal and extraforaminal disc, transforaminal approach is better. For central and paracentral disc, it doesn't matter whether we go for interlaminar or transforaminal approach. However, there will be less nerve root retraction in transforaminal approach. With migrated disc, in my hands, I feel that the interlaminar approach is better. It's more flexible. It's easier to remove the disc as compared to transforaminal approach. However, if there is lateral recess stenosis, I would also prefer the interlaminar approach because I can better visualize the lateral recess. For central stenosis, I approach it with either uniportal stethoscope or UBE. In my hands, I think there is no difference between stethoscope and UBE for stenosis cases. The other things to consider is for patients with multiple comorbidities, transforaminal approach, because it can be done under local anesthesia, is a good option. For L5S1, because of the high iliac crest, interlaminar approach would be better. So in conclusion, surgeon preference and experience is very important. So I think learning multiple approaches and techniques will definitely give the surgeons more flexibility and safety net. The target, we as the minimally invasive surgeons should always be to get an optimal clinical outcome with as minimal tissue damage as possible. And PLDD actually is a very good alternative treatment for contained disc with good disc height. With that, I thank you.